We'll start with the thyroid anatomy. It sits in the neck, in front of the trachea, and it consists of two lobes, a right lobe and a left lobe. The tissue between the lobes is called the isthmus. Sometimes there is an extra lobe that is an embryologic remnant. It sits above the isthmus and it is called the pyramidal lobe. The blood supply for the thyroid comes from the superior and inferior thyroid arteries on both sides. The superior thyroid artery is the first branch of the external carotid artery. The inferior thyroid artery is a branch of the thyrocervical trunk, which arises from the subclavian artery. In the embryologic period, the thyroid diverticulum arises from the floor of the primitive pharynx. It begins as cells in the base of the tongue, and it descends to the neck to form the thyroid. It becomes connected to the tongue with a structure called thyroglossal duct, which normally disappears later on, but it may persist as the pyramidal lobe of the thyroid, which we talked about. The foramen cecum in the tongue is a normal remnant of the thyroglossal duct. As you can see in the picture, this is the median sulcus, and its end is the foramen cecum. There is where the thyroid began to form in the fetus. Sometimes the thyroglossal duct may persist as a kyst, so the patient presents with a midline neck mass that moves with swallowing or protrusion of the tongue. Some people are born with ectopic thyroid, which is a functional thyroid tissue outside the thyroid gland. The most common ectopic thyroid tissue site is the tongue, and it is called lingual thyroid. If you understand the embryology of the thyroid glands, you can easily understand why it is the most common in the tongue. Basically, some thyroid tissue remains in the tongue and does not descend to the neck. A patient will present with a mass in the tongue, usually at the time of puberty or pregnancy. Because of high hormone demands, the ectopic thyroid tissue is stimulated and grown in size. Removal of the ectopic thyroid may result in hypothyroidism because it may be the only functioning thyroid tissue in some cases. Under the microscope, the thyroid tissue appears as follicles. You can see them in the picture. They are circular structures lined by epithelial cells called follicular cells. These are the cells that will produce the thyroid hormone. The follicles are filled with a proteinaceous material called colloids. Thyroid glands produce thyroid hormones, which are iodine-containing hormones that control the body's metabolic rate. Because they contain the element iodine in their structure, it is essential to consume it in the diet. So, to prevent the underconsumption of iodine that leads to hypothyroid disease, most of the salt we eat is iodized, so it is mixed with a small amount of iodine that will prevent iodine deficiency. This is done in many countries nowadays, and that's why iodine deficiency is rare in developed countries. There are two thyroid hormones, T3 and T4. They are synthesized from the amino acid tyrosine and the element iodine. You can see the structure of T3, which is called triiodothyronine, and it contains 3 iodine molecules, and the structure of T4, which is called thyroxine, and it contains 4 iodine molecules in its structure. Before we go on with thyroid hormone synthesis, let's learn more about iodine. The word iodine refers to the atomic structure of the chemical element iodine. The word iodide refers to the salt. It is bound to a positively charged ion, which gives it a negative charge, which could, for example, be iodine combined with calcium or potassium. The iodine in the plasma is found as iodide salt. When the follicular cells take the iodine, it undergoes some changes. First, it is oxidized into I2. This process is called the oxidation of iodine. Then it is incorporated into an organic structure called thyroglobulin, which we'll talk about in a minute. And this process is called the organification of iodine. In the synthesis of thyroid hormones, a protein called thyroglobulin is produced by thyroid glands' follicular cells. This is a large protein containing tyrosine molecules. These tyrosine molecules later on will be converted into T3s and T4s. The first step in the thyroid hormone synthesis is iodine uptake. The protein pump sodium iodine symporter, or NIS, present on the membrane of follicular cells, transports iodine into the cell along with sodium from the plasma. Next step is the oxidation of iodide into I2. The enzyme that catalyzes this step is thyroid peroxidase. The third step is the organification of iodine. The enzyme that catalyzes this step is also thyroid peroxidase. As you can see, it is a multifunctional enzyme that catalyzes many of the steps involved in the synthesis of thyroid hormones. Iodine is added into tyrosine residues on thyroglobulin. If one iodine atom is added, monoiodotyrosine, MIT, is created. And if two iodine atoms are added, diiodotyrosine, DIT, is created as a result. Next, these molecules are coupled. Coupling of MIT and DIT results in triiodothyronine with 3 iodines, while coupling of two DIT molecules will result in thyroxine with 4 iodines. The enzyme that catalyzes this step is again thyroid peroxidase. So thyroid peroxidase, as you can see, is an important enzyme in the synthesis of thyroid hormone. It catalyzes the oxidation and the organification of iodine, as well as the coupling of MIT and DIT. Antibodies against this enzyme are common in autoimmune thyroid diseases like Graves' disease. We'll talk about them in another video. This schematic reviews the synthesis of thyroid hormone. First, the iodide in the plasma enters the follicular cells via the sodium iodide importer. Then, the thyroid peroxidase enzymes takes its place by catalyzing the oxidation of iodide. Then, the organification step where iodine is added into tyrosine residues on thyroglobulin to form MIT and DIT. Then, the coupling of MITs and DITs into T3s and T4s. Later on, the thyroglobulin molecules undergoes proteolysis in the cell, and the T3 and T4 molecules are released. The majority of thyroid product of the thyroid gland is T4, more than 90%. However, T3 is a more potent activator of the thyroid hormone receptor. So, there is an enzyme found in the peripheral tissue called 5' deiodinase that converts the T4 molecules into the more active form T3 within the tissue by removing one iodine from the 5' position. The anti-thyroid medication decreases the thyroid hormone effect by inhibiting these enzymes. The enzyme thyroid peroxidase is inhibited by both propylthiouracil and methimazole, while the peripheral enzyme 5' deiodinase is inhibited only by propylthiouracil, and it is also weakly inhibited by beta blockers like propranolol. Thyroid hormones are the major regulators of metabolic activity and growth in the body. They are important for CNS development and bone growth. They have beta-adrenergic effects which affect the cardiac function, and they also have an impact on glucose and lipid metabolism. If we look into its metabolic effects, the thyroid hormones speed up carbohydrate metabolism, increase glycogen breakdown rate, and speed up gluconeogenesis. Thyroid hormones also increase fat metabolism. They increase the rate of lipolysis. They also increase the cholesterol secretion in the bile and decrease the total cholesterol. They increase the number of LDL receptors in the liver, which leads to lower LDL cholesterol levels. So if we have a quick look at the lab features of hypothyroidism and hyperthyroidism concerning these effects, in hypothyroidism we see hypercholesterolemia because the fat metabolism slows down and the cholesterol levels rise. In hyperthyroidism we see hyperglycemia because carbohydrate metabolism speeds up and there is more glucogenolysis and gluconeogenesis. The thyroid hormones speeds up the basal metabolic rate, so the cells use more energy, produce more proteins, and burn more fats. They do that by increasing the number of sodium-potassium ATPase pumps, so more ATP is consumed and more oxygen is used. This raises the respiratory rates and body temperature. In hyperthyroidism, patients usually lose weight and sweat because of the highly increased metabolic rates. The thyroid hormones increase the body's sensitivity to catecholamines, which increases the sympathetic beta receptor effects. This leads into an increase in cardiac output, heart rate, stroke volume, and contractility. And in hyperthyroidism patients, this develops into tachycardia. Thyroid hormones also have an important role in CNS and bone maturation. It accelerates cortisol synthesis and stimulates bone resorption. Hypothyroidism in children causes cretinism. They have mental retardation and growth restriction. We'll discuss more in another video. Because thyroid hormone synthesis requires iodine, high consumption of iodine in the diet results in a sudden exposure to excess iodine. So the thyroid has a special effect called the Wolff-Chaikoff effect. This is a protective autoregulation, where the thyroid peroxidase enzyme, which we talked about, is inhibited after the exposure to high iodine levels in order to avoid high thyroid hormone synthesis. In the regulation of thyroid hormone synthesis, the hypothalamus releases thyroid-releasing hormone, TRH, which will stimulate the anterior pituitary gland to release thyroid-stimulating hormone, TSH, which will stimulate the thyroid follicular cells. The production of thyroid hormone by follicular cells of the thyroid gland is regulated by thyroid-stimulating hormone, or TSH, also called thyrotropin. TSH is released by the anterior pituitary gland. It binds to receptors on the thyroid follicular cells and stimulates them to release more thyroid hormones. It works via the cyclic AMP protein kinase A second messenger system. TSH triggers various mechanisms to enhance the release of thyroid hormone. It can rapidly increase the amount of T3 and T4 released by increasing thyroglobulin proteolysis, and it can also have a slower but sustained effect by promoting the growth of the thyroid glands and the synthesis of thyroglobulin. When the levels of thyroid hormones in the plasma rise, they produce a negative feedback inhibition on the hypothalamus to produce less TRH, and also on the anterior pituitary to become less sensitive to TRH stimulations. Thyroid hormones are poorly soluble in water, so they need a carrier molecule to move in the blood. Thyroxine binding globulin, or TBG, binds most of the thyroid hormones in the blood. A small amount of thyroid hormones is bound to albumin and transthyretin. Despite comparatively smaller quantity of TBG in comparison to albumin, it binds most of the thyroid hormones due to its high affinity for them. TBG protein is produced in liver. If there are low levels of TBG in the plasma, total thyroid levels, so T3 and T4, will be low, and less thyroid hormone will be available for tissue. To understand how this happens, you must first know that the bound thyroid hormones are biologically inactive, while the free form is the active form. The active form is sensed by the pituitary gland, which releases thyroid-stimulating hormone, or TSH, only if the free thyroid hormone levels are low. So, if you understand this concept, now imagine that TBG levels became low for some reason. Fewer thyroid hormones will be bound and biologically inactive, and more will be free and active. So the pituitary gland senses high thyroid hormones, which will inhibit TSH release via negative feedback. That, in result, will decrease thyroid hormone release from the thyroid gland, and there is a decrease in total thyroid hormone. And when the free thyroid hormones go back to normal, TSH also goes back to normal. As a result, a patient with low TBG will show normal TSH, normal free T4, and decreased total T4. And vice versa. A patient with high TBG will show normal TSH, normal free T4, and increased total T4. In liver failure, the liver is unable to produce enough proteins. One of those proteins is TBG, so this results in low TBG levels, which will measure low total T4 levels in the lab. TBG is also decreased in nephrotic syndrome, where proteins spill into the urine. It's also worth to know that the estrogen hormone raises TBG levels, so women who are pregnant or women who are using oral contraceptive pills can have raised TBG levels, and this shows high total T4 levels in the lab. The thyroid panel is the standard panel that we measure to assess thyroid function. First, the TSH is measured, followed by the total T4, total T3, and the free T4. You don't need to know the exact numbers, but you must not forget that the T4 levels are much higher than the T3, and the total T4 is much than the free T4, as we discussed. There are other measurements included in the thyroid panel when pathology is suspected, like reverse T3 and anti-TPO antibodies, which we'll discuss in the next video. Besides thyroid hormones, The thyroid glands also produce another hormone called calcitonin. It is synthesized by the parafollicular cells, also called C cells. Calcitonin's major effect is to lower the serum calcium level. It does that through several effects. It suppresses bone resorption by inhibiting osteoclasts. It also inhibits renal reabsorption of calcium and phosphate. And it also increases the amount of calcium in the urine. It plays a minor effect in calcium regulation because the parathyroid hormones are the major hormones that regulate calcium. However, it is used as a pharmacologic therapy for hypercalcemia. We'll discuss more about calcitonin and parathyroid hormones in the calcium regulation lessons. That was all for this lesson. Now let's review some points of what we learned. Thyroid glands produce thyroid hormones, which are iodine-containing hormones that control the body's metabolism and growth. The hypothalamus releases TRH, which stimulates anterior pituitary gland to release TSH, which will stimulate the thyroid follicles to produce T3 and T4. Mostly T4 is produced, and it is converted into T3 in the peripheral tissue by the enzyme 5' deiodinase. Most of the thyroid hormones are bound to TBG. In the thyroid hormone synthesis, iodine is uptaken, then it undergoes oxidation, organification, then the coupling of MIT and DITs occur, all catalyzed by the enzyme thyroid peroxidase. Thyroid hormones increase the basal metabolic rate, stimulate growth, and activate sympathetic adrenergic receptors. This concludes our discussion about the subject. If you want to test your knowledge by solving the questions, continue the video. The thyroid hormone increases heart rate and cardiac output by increasing the sensitivity of sympathetic beta receptors in the heart. And by increasing the basal metabolic rate, the cells use more oxygen and consume more energy, which increases body temperature as well. Estrogen increases thyroid binding globulin levels, so women in pregnancy have high TBG levels and high total T4.